walk us through the key findings of the sensitivity analyses and how you would say they may support or modify the interpretation of the trial's primary results?
For the win ratio, as we look at them into the different strategies, I mentioned the two different methods that we use to analyze the data. The first one was that overall, just get rid of them altogether, exclusion of all participants who had any tafamidis. The win ratio percentage breakdown for all-cause mortality, 70% of ties remained, so 30% of ties were broken. So not a small number, but for the most part, this was the smallest number of ties that were broken for the strategy where we exclude tafamidis use. Whereas in the one where we exclude events afterwards, 77% of ties remained, or a smaller number of ties were broken. So as we get down to the second stratum, the second hard outcome measurement for CV hospitalizations, in the initial overall primary analysis, it was around 45% of ties that remained after we looked at cumulative frequency of hospitalization. For the hypothetical strategy, 50% remained. In the hypothetical strategy is the one where we're just getting rid of all events after the start of tafamidis. And then the principal strategy was the one where we exclude people altogether, and that was still 44%. So the almost identical number as with the overall study analysis. So the bottom line there is that there was no difference really in the outcome measures that we looked at, including the hard outcome measures of all-cause mortality and CV hospitalization, by removing or stratifying based on tafamidis use.
And from your perspective, what are the clinical or biological factors that may explain some of that sustained efficacy of acoramidis that was observed in the study, even when some of those participants, as we discussed, were also receiving tafamidis?
Yeah. So I think one of the things we all want to do when we're looking at two different drugs for the same disease is to compare them, to say, well, like, which one's better? And we can't do the cross-trial comparison. We all know as a study that was done and published 5 years ago is going to be different than the study in the same disease, but a different time frame when we're finding the disease earlier. So it's really, I think, a mistake to do cross-trial comparison, despite how interesting and compelling it is to try to do that. So instead, as we look at a more direct way of answering the result, like how did this still make a difference, and can we infer anything about the benefits of acoramidis compared to tafamidis? Well, if we look at blood levels of TTR, remember both of these drugs stabilize the TTR tetramer. So the stronger the tetramer is, the less a monomer is able to misfold and deposit in diseased tissue like the heart. On the other hand, if the drug is not stabilizing quite as well, then the TTR level, the serum prealbumin level, because prealbumin and TTR are the same thing, we measure that. And when we measure it, acoramidis raises the level much more than tafamidis does. So in the study, I mentioned 14.5% of people overall were taking tafamidis. Those who took tafamidis and that were on placebo in the beginning, so they had a baseline prealbumin level. At the end of 12 months or 15 months or wherever it was that they started, their TTR level went up in response to tafamidis. And then when we got to the open label extension, we were able to see, is there any additional change? And there was, in fact, an increase in those who were on tafamidis alone plus placebo, who then switched over to acoramidis. When we do the opposite, when we said, for those who were taking acoramidis from the beginning, we had a baseline level, and then we had a 12-month level of their prealbumin and on acoramidis. And then what happened if they started tafamidis afterwards? Did that level go up any higher? In fact, it didn't. Matt Maurer showed that data at ACC, and it was really exciting to see what we believe is a good marker of TTR stabilization and a differential effect based on acoramidis and tafamidis.